and the patient is going to present with a mask-like face, beak-like nose, and fish-like mouth. In this, it is systemic because many of the major organs are involved, like kidney, lung, muscles, heart, and GID. And there is a crest syndrome in which there is calcinosis, which is dystrophic calcification in the areas of damage and necrosis, and Raynaud's phenomena, esophageal dysfunction, sclerodactyly, and telangiectasia. So this is a typical of patient with scleroderma. Scleroderma patient is going to present with long pencil-like fingers because of the excessive fibrosis in the dermis, and that is going to contract the skin, and it is going to stretch the skin above the on the fingers and on the bones. So this is the appearance of a patient with scleroderma: thin pencil-like fingers, tapering fingers. This is a typical facies of a patient with scleroderma. So a thin beak-like nose because of the stretching of the skin over the nose, and a fish-like mouth because of the stretching of the muscles and the skin over or around the mouth. So whenever there is fibrosis, and fibers are collagen fibers, they are going to contract. So there is excessive, useless deposition of these fibers because of the proliferation of fibroblast, and they are going to produce fibers. And whenever there is deposition of fibers, they are going to contract, and they are going to stretch the tissues around them. So this is scleroderma, a clinical diagnosis. So if you see a patient like this, you may order um, the antibodies against our own tissues, and we can go to the final diagnosis. But as I told you in the previous lecture also, that a good history, a good clinical examination, and um, regarding the autoimmune diseases, the history of viral infections, chemical exposure, and drug intake is important. So only then we can find out that are we dealing with an autoimmune disease or not, because autoimmune diseases cannot be cured, they can only be prevented, and the complications can only be prevented, or the time for the complications can be lingered by certain treatment options. Immune therapy can be one of the options, but it is not marketed in all the autoimmune diseases at the moment. So scleroderma can be limited to the skin, or scleroderma can be diffuse. Scleroderma can be systemic, so you can call it systemic sclerosis. So this is something related to when we are dealing with scleroderma clinically. Scleroderma can be localized or systemic. It can be in the form of a morphea or a linear scleroderma if we are dealing with a skin or a patient in dermatology. It can be limited or it can be diffused, involving the entire body skin. So this is something you are going to deal with when you are going to go to the clinics. So a patient may present with Raynaud's phenomena, skin involvement, muscle, GIT, pulmonary or cardiac, and renal involvement. So you can see that in this case, renal involvement is less than SLE, because 50% of the patients with SLE are going to present for the first time with the renal disorders, and 100% of the patients with SLE will ultimately develop renal dysfunction and may die because of the renal failure. This is Crest syndrome, and Crest syndrome means C is for calcification, and calcification is dystrophic calcification in the dermis, in the areas where there is excessive fibrosis, and there is degeneration of the surrounding tissue. So there is deposition of the calcium from the serum into that degenerated tissue. The serum calcium levels are going to be normal, so that is why it is a dystrophic calcification. Raynaud's phenomena, there is spasm of the blood vessels in response to cold or stress, and whenever the hand is taken out of the cold water, it is going to um, appear normal again after some time. So this is Raynaud's phenomena. Last time somebody asked a question that what is Raynaud's phenomena. Make it very clear. Raynaud's phenomena and Raynaud's disease, they are two different things. Raynaud's disease is a type of vasculitis. You're going to study in detail in pathology of blood vessels in fourth year, while Raynaud's phenomena can be seen in a number of diseases, that may be autoimmune diseases and some other diseases, also some inflammatory diseases. Esophageal dysfunction is that the there is fibrosis in the lamina propria of the esophagus, that the patient is going to have difficulty in swallowing the food, and there is going to be acid reflux and decrease motility of the esophagus. Sclerodactyly is thin pencil-like fingers because of the stretching of skin over the bones. And telangiectasia is dilatation and then rupturing of the small capillaries underneath the epidermis. That is again because of the fibrosis around those capillaries. They are going to burst and form small collections of blood underneath the skin, which are going to appear as telangiectasias. Telangiectasias are small hemorrhages under the skin. So clinically, there is diffuse and limited scleroderma, and you can see the feature that in cases of diffuse, there is excessive lung fibrosis, and heart can be involved or kidney can be involved. Large joints can get deformed because of the contractures, and in this case, the difference between SLE and scleroderma is that in SLE, the joint itself is involved, and there is arthritis, while in scleroderma the large joints are deformed because of the fibrosis in the dermis around the joint, and the contraction of the fibers, they are going to produce deformities. So there are contractures rather than a proper arthritis. Then there is disability, fatigue, and then muscle pains. While in limited, you have lung fibrosis, minimal heart or lung disease, late pulmonary disease, and then biliary cirrhosis. Then, while ordering the antibodies, if we have to confirm that this is scleroderma, first we are going to order ANA, that is anti-nuclear antibody, to rule out anti autoimmune disease, and then particularly for scleroderma, we are going to order anti-centromere antibody, which is seen in most of the cases of scleroderma. Then anti-topoisomerase antibodies. There are certain other antibodies you can see in the table. You don't have to actually order all the antibodies, so you have to know one or two antibodies for each disease or each common autoimmune disease, so that you can order that antibody and come up with the diagnosis. So in cases of the scleroderma, after ordering ANA, and if it comes positive, you are going to order anti-centromere antibody, anti-topoisomerase antibody, and that is going to form the diagnosis. The clinical features are going to then determine whether it is diffuse or a limited disease and which organs are involved. Another autoimmune disease is Sjogren's syndrome, or there is another pronunciation, Sjogren syndrome. So anything you want to say, the most common is Sjogren syndrome. Sjogren syndrome is seen in again in females most common, middle-aged females, 20 to 40 years of age. There is keratoconjunctivitis, which is dry eyes. There is xerostomia, which is dry mouth. Now, this is a disease in which the salivary glands are involved and lacrimal gland is involved. So the disease initially presents with localized autoimmune disease involving only the glands, that is the lacrimal and salivary glands. So there is less or no formation of tears in the eye and no or less formation of saliva. So that is going to produce dry mouth and dry eyes. The patient is going to present with gritty or sand like feeling in the eyes, and it's going to present with dry mouth. The patient may present with arthritis later on as a complication, and there is increased risk for the development of lymphoma. And this type of lymphoma is actually not in the lymph nodes, but it is in the salivary gland or the lacrimal gland. So this lymphoma is called mucosa associated lymphoma. You all know what is MALT, that is mucosa associated lymphoid tissue. So mucosa associated lymphoid tissue is present in all our body, and particularly in the GIT and the respiratory tract, but it is also present in the other organs and other systems of the body also. So you have mucosa associated lymphoid tissue in the salivary glands also. So the lymphoma developing in such areas is mucosa associated lymphoma, but the type of the lymphoma remains as the one in the lymph nodes. So it is going to be a B cell lymphoma or a T cell lymphoma. Most commonly, it is a B cell lymphoma. So, lymphoma in a long standing untreated Sjogren syndrome. So, this is one of the complications, and the patient may present with lymphoma in the salivary glands. So Sjogren syndrome, the patient is going to present with dry eyes, and those dry eyes are ultimately going to lead to the infections or recurrent conjunctivitis. So dry eyes are going to present as red eyes. There are no tears, because tears are actually lubricating our eyes and also saving us from the environmental pollutants and the microbes. So the patient is going to present with recurrent uh, conjunctivitis, the viral or bacterial conjunctivitis, that is because of the dry eyes. This is one of the tests you can do by putting a filter paper and determining the extent of the tears produced. Same way, in case of dry mouth, you can determine the production of saliva if you give certain um, eatable or like chewing gum. The patient is going to chew the chewing gum, and you can determine whether the saliva is produced or not. And if you want to determine the amount of saliva produced by chewing a chewing gum, you can collect that saliva and determine that how much saliva is produced, and you have to compare it with a normal person. That is going to determine how dry the mouth is. Dry mouth is again one of the nuisance, because the patient is not going to swallow or chew the food properly, and the mouth is prone to develop oral ulcers, oral infections, because saliva again is one of the protective first line defense mechanism against the microbes and the pollutants. So in case of Sjogren syndrome, there are dry eyes and dry mouth. There is gritty, sandy feeling, and recurrent conjunctivitis. Dry mouth, there is sore throat, there is cracked tongue, burning throat, difficulty in talking, swallowing, or chewing the foods. Even there is alteration in the taste and smell, and there are cracked lips and sore mouth. So you may have swollen parotid glands. That is because of the chronic inflammation going on in the salivary gland because of the auto antibodies. Auto antibodies are going to attach to the antigens in the salivary gland, which is going to stop the production of the saliva. And as we know that whenever there is antigen antibody complex formation, there is initiation of the complement system. So actually there is inflammatory process going on in the salivary gland for no reason, and that is going to linger on as a chronic inflammatory state. So that chronic inflammatory state for a longer time is going to be predisposing the salivary gland to the formation of a lymphoma. So all the other symptoms are related to the dryness of the mouth and the eyes. Same way, other glands in the bodies, they may also be involved. For example, there is a dryness of the vagina because of the involvement of the Bartholin glands, and there are no secretions. So again, there is vaginitis and infection of the vagina. Musculoskeletal system is involved in 60% of the cases, and then there is formation of um, lymphoma, and other organs are involved less likely in Sjogren syndrome because the patient is going to present in the initial stages of the disease, and you can just treat the patient. So this is just to show you the frequency of other organs which can be involved in Sjogren syndrome. You don't have to remember all these tables. You're going to go into the details when you're going to go to the clinics in medicine. So just to remember Sjogren syndrome, what are sign and symptoms, what is the mechanism of Sjogren syndrome, and what is the increased risk for Sjogren syndrome, that is formation of a lymphoma or the cancer of the salivary gland, and as a complication. It is not the first presentation. So regarding the treatment, there is no cure as it is an autoimmune disease. You cannot remove the autoantibodies, but you can give palliative treatments like lubricants for eyes, artificial tears, and then lubricants for the mouth, and then certain medicines regarding the dryness of the mucosa in the nasal cavity, and then prophylactic antibiotics. Okay, so this was all about Sjogren syndrome. Uh, Another autoimmune disease is dermatomyositis. Myositis is inflammation of the skeletal muscle. Dermatitis is inflammation of the skin, that is the dermis. Dermatomyositis is an autoimmune disease. Dermatomyositis is going to involve the skeletal muscle as well as the skin. So you have to be very careful what you are dealing with, because you may be dealing with a simple dermatitis, or you may be dealing with a myositis. So this is one of the tricky autoimmune disease, that first you have to rule out all the other diseases related to the skin or the muscles. You have to take a very good history to rule out any history of trauma or any muscle disease or injury, and then certain diseases related to the skin, and then go for the diagnosis of dermatomyositis. Again, emphasizing on the fact that you don't have to miss an autoimmune disease, which is a very common practice, but you don't have to put this disease on the top of the differential diagnosis. This is at the last of the differential diagnosis, when the patient is going to present with muscle pain or a redness of the skin. So this is how the cross section of the muscle looks like under the microscope, and you can see the chronic inflammatory cells. Those are lymphocytes infiltrating in between the muscle fibers. The muscle fibers are going to get destroyed because of the inflammation, and this inflammation is because of the autoantibodies against the antigens on the skeletal muscles and in the dermis that is going to provoke the inflammatory response. This is a raccoon. So, a very typical rash seen in dermatomyositis is a raccoon like rash around the eyes. So, this is a heliotropic rash around the eyes, and these are called raccoon eyes. So, as I told you that whenever you are dealing with the dermatomyositis, or you are coming up with the differential diagnosis in the clinic, after looking at the patient, you have to see certain types of rash to come up with the diagnosis of dermatomyositis. And one of them is this heliotropic or raccoon like rash. So there are certain rashes of dermatomyositis. One is heliotropic rash, that is a rash around the eyes or on the eyelids. Gotron sign is hands and phalangeal joints. That is rash on the hands and the phalangeal joints. Mechanic's hand is a rash on the palm, on the radial aspect of the fingers. It is just like if you see a mechanic holding a tool while working, that is the area where the tool is um, adjacent to the hand. So that is why it is called a mechanic's hand. Shawl sign is a rash on the posterior neck and the shoulders. This is that how a female or anybody is putting a shawl on the shoulder. A V sign is the interior neck and chest, as we wear a V-shaped shirt. That is the part which is exposed is the V sign, and there is a rash in the on the interior part of the neck. And then there is a sign that is a torso sign. Torso means the nape of the neck, and the portion between the scapula. So it is like the hump of the bull. So torso sign is rash on the nape of the neck and in between the scapula. So let us see the pictures of all these. So you can see the rash on the eyelids. This is the heliotropic rash. Or if you have a rash all around the eyelids or the eye, that's called a raccoon's eye or raccoon sign. You may have rash on the hand, particularly on the joints of the phalanges. You may have a rash on the palmar aspect of the fingers, and this is called a mechanic's hand. This is a shawl sign, so you can see a rash, particularly on the areas where you put the shawl. This please make it very clear that these signs are just the names given to the features which can be seen on a particular part of the body. This sign is not because of the shawl or not because of the tool a mechanic is using. This is just the name given to the rash, particularly seen at a particular area. This is a V sign or a V like rash. This is the torso sign or a rash on the nape of the neck and the area between the scapula. So these are some of the signs you can see, particularly if you want to diagnose dermatomyositis. So this is very, very important that you don't have to label a patient with dermatomyositis if you see such rash. First, you have to rule out any of the skin diseases. If that is not just a skin disease, then you can order an antibody. You don't have to remember this. I'm just showing you that you um, have to you are going to see this in your medicine board, but you have to first go for the history, then a good proper examination with all those signs in the skin, and then you have to go for the muscle enzymes. You have to see the levels of the muscle enzymes and the level of the muscle wasting. You can go for electromyography, and then you can go for muscle biopsy at last to rule out whether it is an autoimmune disease or some other muscle disease. So there is a difference between polymyositis, dermatomyositis, or a scleroderma. So again, in this case, there is inflammation of the skeletal muscles, and there is dermatitis. Same way in scleroderma, there is hardness or hardening of the skin because of the excessive fibrosis in the dermis. So be very careful in while diagnosing that whether you are dealing with a scleroderma or a dermatomyositis. You may have muscle weakness in dermatomyositis, but you have to rule out the muscle diseases or especially the history of trauma first, and then go for the inflammatory process and the serum enzymes, and then the biopsy of the muscles. And in cases of scleroderma, you don't have such muscle weakness or the involvement of the musculoskeletal system as in dermatomyositis. You may have fibrosis, or you may have deformity of the joints, which is actually because of the fibrosis around those joints. The patient may present with CREST syndrome in case of scleroderma. So these are some of the differences between these two. At the end, this is ANA disease association. As I told you that anti-nuclear antibody can be seen in a number of diseases, autoimmune diseases. So see this, that you may have a positive anti-nuclear antibodies in SLE, in drug-induced lupus erythematosus, in rheumatoid arthritis, scleroderma, in polymyositis, dermatomyositis, and Sjogren's syndrome. So you have to go for a particular antibody related to that one disease to come up with a diagnosis. That may be a double-stranded DNA, a single-stranded DNA antibodies, histone antibodies, anti-centromere antibody, nucleoprotein antibody, anti-Smith antibody, and so on. So you have to remember one or two antibodies for all these diseases. These are some of the diseases you have to remember in your third year, and the most common ones are SLE, scleroderma, Sjogren's syndrome, and then polymyositis. So there is a long list of autoimmune diseases. You just have to go and read the list once only, just to know that you are going to deal with such diseases in future. But these are the diseases you have to remember, and you may get MCQs on these or an SCQ, particularly on SLE. Immune deficiency. can be congenital or can be acquired. One of the examples of acquired immune deficiency we already did was HIV and AIDS in detail. Immune deficiency can be congenital, and if it is congenital or hereditary, these are some of the warning signs. If you see in an infant, a neonate, or a baby, uh, like recurrent infections, most likely with bacteria, fungus, and then parasites. So these are some of the signs, and all those signs are actually related to the infections. And if those infections are not treated with the standard antibiotics, you may go for diagnosing any autoimmune deficiency. Sorry, immune deficiency. It is not autoimmune. So primary immune deficiency can be, these are some of the common primary immune deficiencies which are hereditary or congenital: selective IgA, IgM immune deficiency, common variable immune deficiency, severe combined immune deficiency, X-linked gamma globulinemia, chronic granulomatous disease. So in all these diseases which are hereditary and they are immune deficient diseases, one of the components in the immune system is deficient or defected. So that may be an antibody, that may be a cell, or that may be any part of the complement system. So there is deficiency of one of the parts of the immune system. So in cases of cells, T cells and B cells both can be deficient or defected. So any of the organs can be involved in combined, severe combined immune deficiency or variable immune deficiencies, and the patient may present with clinical sign and symptoms of infections of that organs or the tissues. Hyper IgM syndrome is a rare immune deficiency or immune defective syndrome. That is that whenever a B cell is forming IgM initially, it cannot switch to another antibody. Um, uh, to make you remember from your previous knowledge that a B cell can form any type of antibodies, and once initially in the infection, it is going to form IgM, and then it is going to switch to IgG. The same B cell can form both the antibodies regarding the stage of the infection. So initially in all the infections, IgM antibody is formed, and then it is going to switch over to IgM antibody. So in this case, hyper IgM syndrome, there is an inability of the B cells to form any other antibody, and IgM is going to linger for a longer period of time, and that may produce certain abnormalities. Wiskott-Aldrich syndrome is an X-linked primary immunodeficiency, which is going to primarily present with vasculitis. And that vasculitis is mostly in the dermis, and the patient may present with ulcers or um, wounds that are not healing properly. Severe combined immune deficiency is that there is a severe deficiency in both the cells and the antibody formation, and this is what we call a bubble baby. The patient or the baby is prone to any of the environmental pathogens and is prone to develop infections rapidly. So in cases of X-linked severe combined immunodeficiency, there are gene mutations coding for the cytokine receptors. for example, especially interleukin 7. So see this, that only a single receptor defect can lead to such big disease, and the patient is prone to bacterial, viral, fungal, and protozoal infection. The death of the patient is not because of the disease itself, but it is going to be because of the recurrent infections which are not cured properly. Autosomal severe combined immunodeficiency. Again, there are certain mutations, and the patient is prone to infections. Com- Common variable deficiency is a defective immunoglobulin production, and the causes are unknown, but there are certain genes linked to this. This may also lead to formation of auto antibodies. This is to show you that this is a table which you might have seen in your second chapter on inflammation. Uh, there are certain deficiencies in the inflammatory mediators which can lead to immune deficiency states. So, hereditary angioedema, edema, which we did in our hemodynamics, is again one of the immune deficiency states. And then there can be deficiency in this complement system, particularly because whenever there is combination of antigen and antibody, there is activation of the complement system. So deficiencies of all this may lead to a number of immune deficiency diseases, but all of them are hereditary or a congenital immune deficiency. Again, this is from your chapter on inflammation. This is a table in Robbins. Chronic granulomatous disease is that there is defective production of reactive oxygen intermediates by phagocytes, and there are recurrent infection by bacterial and fungal pathogens, and particularly by pathogens in which there is formation of granulomas. That is why it is called chronic granulomatous disease. So chronic granulomatous disease is not one disease which we are dealing with when we say this term, chronic granulomatous disease. That means that we are dealing with a congenital disorder. In case of other individual diseases like tuberculosis, you have to take the name of the disease. You may say that it is a chronic granulomatous infection, most likely tuberculosis, or a fungal infection, or a bacterial or a protozoal infection. But when we label a patient with chronic granulomatous disease, that is a congenital immune deficiency disease in which there are infections in which there is granuloma formation. Then there is leukocyte adhesion deficiency 1 and 2, and then there are other lysosomal dysfunctional diseases which may lead to immune deficiency. Immune therapy is immune therapy is in one of the big branches of immunology, and immune therapy is underway in progress, and it is going to be one of the treatment options in future. And immune therapy is particularly involved not only in the immune diseases or the autoimmune diseases or the immune deficiency diseases, but it is also very popular in neoplasias. So the treatment of cancers, immune therapy is one of the options now, and many immune related drugs or drugs related to the immune systems are used in certain neoplastic patients. So lastly, this is something to show you that what can be the causes of secondary immune deficiency. So
Dr.
in
Nan, just 1 minute left.
okay, so previously in the previous slides, the congenital or the hereditary immune deficiency is called the primary immune deficiency, and secondary immune deficiency is after birth, which can be because of malnutrition, HIV infection, malignancy, a patient of chemotherapy on or radiotherapy, immunosuppressive drugs, immunomodulatory drugs, or patients of transplant, metabolic disorders, long-standing chronic disorders like diabetes or liver disease, or hypertension, patients on long term drug intake. So the secondary immune deficiency is that you have to rule out all these causes to come up with the diagnosis. So this was all about the diseases related to the immune system. We are going to have another new topic next time. So thank you very much for your patience listening.